Hello, everybody. It's Emily Henson, and I will be giving the presentation on behavior theory that comes from Chapter 9 in our textbooks. First, I'd like to go over the contributors to behavior theory. We first have Burrhus Frederick Skinner, also known as B.F. Skinner. He was born in 1904. He would say that he had a very stable childhood growing up, and he received his PhD in 1931 in psychology at Harvard University, where he would later end up teaching. He passed away in 1990. In our book, it claims that B.F. Skinner is the father of the behavioral approach. He believes that the primary focus on this therapy was the effects of our environment on someone's behavior. So he thought that there were too many theories and too many people that were focusing on internal causes to an individual's underlying disorders or struggles that they may have. And he didn't think that there was enough focus on the environment and how that truly affects an individual. He did understand that feelings and thoughts were there and that they are very important. And he doesn't disregard it, but he wants people to understand that he doesn't believe it's the primary cause of our actions. So something that he did do personally in his life would be to practice reinforcement, which he would often go into a tent and play classical music. He would put on headphones and listen to classical music in like a cocoon such form where he could really just calm down after a long, hard day. And I feel like a lot of us wish and want we could to do that, but I know I don't always have time, but I think that's pretty awesome that he did that in his own life. Next, we have Albert Bandura, who was born in 1925 in Albert, Canada. He received his PhD in 1952 in clinical psychology from the University of Iowa. While he was working at Stanford, him and colleagues studied social learning theory and deemed it as a prominent role of observational learning, social modeling, motivation, and thought. In the mid-1980s, Bandura named his approach social cognitive theory. He differed from Skinner and believed that we aren't just reacting to environmental forces, but we are being driven by small impulses. So this was a big change that he felt behavior theory needed and that it lacked, was that it wasn't focusing on that specifically, and it was a little too much towards the environmental and still needed to pull back on some of the small impulses that we have. Next, we have John B. Watson. In a lot of my readings, they considered him the father of behaviorism, and though that differed from the book, I do feel that it's very important that his incorporation from Pavlov's classical conditioning is a key point in this theory, where he emphasized that all information can be found in research. So research of an individual, research of many different things, you can find it. You just got to put in the time. And Ivan Pavlov, his contributions were very accidental. He was studying the digestive process of dogs, and he discovered how associations can develop when pairing stimulus that has a response, which is considered classical conditioning. So his contributions may not have been exactly towards behavior theory, but in return, it gave us some clear information on this theory in general. So the timeline of behavioral approach. In the 1950s, behavior theory begins in the United States, South Africa, and Great Britain. So behavior therapy begins. What does that exactly mean? So behavior therapy focuses on observable behavior that is caused from the environment and what experiences that these give individuals that create decisions in their lives. Behavior therapy is used in a lot of different disorders and developmental disabilities. It's also used in some education, and I think that's very important to understand that it is very broad and it's helped a lot of different areas. So it's not just focused on the counseling realm too. It can really be focused on a lot of different aspects in child rearing and helping people understand just life a little bit better. So in the 1960s, Albert Bandura developed social learning theory and many other cognitive approaches. In the 1970s, contemporary behavior therapy begins to arise. This was a large hit on the education, psychology, psychotherapy, psychiatry, and social work aspects because it was helping a lot of people with child rearing problems. And behavior therapy was a major dive into psychological disorders. So this was a big, big important moment. In the 1980s, our book describes it as a search for new horizons, concepts, and methods in this theory that were not being focused on enough that people found time to focus on more and dive into. In the 1990s, ABCT, which is the Association for Behavioral and Cognitive Therapy, claimed a membership of about 3,500, and now it has about 6,000 members that are interested in this theory. In 2000s, this therapy became brought into what the book and many people would call the third generation or the third wave. I really like that terminology that it gives, where we learn about DBT, MBSR, NBCT, and ACT. So now we're going to look at some 4 areas of contemporary behavior therapy. First, we have classical conditioning, which is what we earlier described as Ivan Pavlov's accidental learning for this therapy, where he believes, and everyone that focuses on this believes, that before learning, this is what happens before learning and will create a response through pairing. So his example with the dog that he was doing his research on was that putting food in a dog's mouth will cause it to salivate, and this is a responded behavior. When the food is continually presented with a different response, such as the sound of a bell, the dog will begin to salivate to the sound of the bell. But if the bell is diminished without the pair of the food, then salivating to the sound of a bell will diminish. Next, we have operant conditioning, which is a type of learning when our behaviors are determined by the consequence that follows them. So it's what we do in a daily life. So riding, driving, walking, simple things like that. Third, we have social cognitive approach or social learning approach, which basically is the environmental events that determine behavior are determined by how an individual will cognitively process how these environmental influences are interpreted in their mind. Last, we have cognitive behavior therapy, which is something that we will be learning about more in the next presentation, but it's important to note in this therapy because it is very popular and is very similar and based out of this. So next in our book, it gives us 7 characteristics of this therapy, which I think really help us understand what this therapy is about and what it wants to generally focus on for an individual. So first, we have behavior therapy is really focused on the principles and procedures of a scientific method. So it's more scientifically based. A lot of B.F. Skinner's work was in a laboratory and experimental, so that's an important note of this therapy. Something can be operationally defined. Behavior therapists look at the current environmental events that cause behavioral problems and help clients look at these events and change their behavior. This therapy isn't just a communication therapy, but an action by the client. So the client really has to want to make a change, or this therapy is really hard to do because it's very action based, and that's a clear defining part of this theory. So change can happen without looking at the underlying dynamics, so that it doesn't focus on more of why you're making a decision because this happened to you in the past. It doesn't disregard the past, and it just doesn't believe that that is the main focus in this therapy. So assessment is a big focus in this therapy. Assessment will happen throughout the whole treatment process, and this is huge in determining if what they're doing is actually working. And lastly, each client is different, so intervention is specific for clients. So you can't have a client come in and say that they have anxiety, and then you just clear cut to the treatment easily used for anxiety. You have to really get to know this client and understand the best treatment that will happen for them, because environment is a big part of this theory. So if you're not understanding their environment, you're probably not going to be able to understand the best treatment to give them. Next, we have the goals for this theory. I included this little quote by B.F. Skinner, which is kind of fuzzy on here, but I'll read it out for you. The ideal of behaviorism is to eliminate coercion, to apply controls by changing the environment in such a way as to reinforce the kind of behavior that benefits everyone. I thought that was really good in summing up what he was really trying to accomplish in this theory. So the goals for this is to make specific treatment plans. Assessment will happen throughout the whole process. In contemporary behavior therapy, you'll make measurable goals. You always have to remember that the treatment plan can change, and the client therapist will work together to make the best treatment for the unique person. Next, we're going to learn about the ABC model. A meaning antecedents, B meaning behavior, C meaning consequences. So this is how you go about finding the type of treatment. So first you go through a functional assessment, which is also known as a behavioral analysis. So first you will look at information about situational antecedents. Then you will look at the dimensions of a problem behavior, then the consequences of the problem. So the main goal of functional assessment is to understand the ABC sequence in an individual. Our book gives an example of a client who has trouble sleeping well. We'll listen to a relaxing tape to serve as a cure for sleep induction, or turn off the lights, or remove the television from the bedroom. Consequences are events that maintain behavior and a way by increasing or decreasing it in an individual. An example to this is that a client will return to counseling if the counselor gives them verbal praise of completing a homework, such as journaling, that the client was given by the therapist. And a client will less likely return if the counselor is always late to the sessions. And behavior is assessed by doing behavioral assessments, interviews where the therapist will identify the antecedent and consequent events that are influencing the individual's behavior. Okay. All right. So now let's go over those treatment plans. First, we'll go over operant conditioning techniques. There are 5 key principles to operant conditioning techniques. The first is positive reinforcement, which the book states the addition of something of value to an individual as a consequence of a certain behavior. An example that the book gives for this is when a child earns a good grade and their parents praises them for an accomplishment. In return, the student is likely to try harder and study harder to have this same situation happen again. Next is negative reinforcement, which involves the escape from or the avoidance of aversive stimuli. This is when individuals are exhibiting desired behavior to avoid an unpleasant condition. The book gives us an example of a person not liking to wake up to the sound of an alarm, so they train themselves to wake up a few minutes before the alarm sounds every morning. Next is extinction, which is withholding reinforcement from previous reinforced response. The book states that an example of this is a child that's having a temper tantrum. The parents will reinforce his behavior by the attention that they give to it. An appropriate way to deal with this is to ignore the behavior and not to apply positive reinforcement, which would be attention, to the situation. This can be really hard. I'm not a mom yet, but I know that it could be really hard not to give in to a kid that's screaming after a long day that you've had. But this is a positive way of looking at it, I guess. Next is positive punishment, which is an aversive stimulus that is added after behavior to decrease the frequency of this behavior. Next, we have progressive muscle relaxation. The main goal of mental and muscle relaxation is to help individuals have full muscle and mental relaxation. It's really important that when people are going through this process that they continue this on a daily basis, because it is hard for this process to work if it's not repetitive. The clients will get a lot of information on how to relax properly and instructions on how to make this work in their specific life. This helps people get ready for surgery or teaching clients how to cope with chronic pain and reducing the frequency of migraine attacks. Next, we have systematic desensitization, which is based on the principle of the early talked about classical conditioning and its basic procedure that Joseph Wolpe developed. This helps clients with anxiety-arousing situations, while at the same time engaging in a behavior that competes with anxiety. Through this process, gradually a client will become less sensitive or desensitized to the anxiety-arousing situation. This can be considered a form of exposure therapy because clients will expose themselves to a situation that is anxiety-arousing. This is a very time-consuming process, but very effective and efficient to reduce anxiety-specific problems. To complete this, there will be an interview process that will last various sessions where the therapist really has to understand the individual. The first step to systematic desensitization would be to go through progressive muscle relaxation and start with that process, and then go into a session where they develop a level of anxiety. So you'll start by making an anxiety hierarchy. You'll range the list of situations that cause anxiety It'll start with the most anxiety-provoking situation down to the least anxiety-provoking situation. After several interviews have been completed, desensitization will happen. This process with a client reaching complete relaxation with their eyes closed. A scene will be presented to the client while they have reached complete relaxation, and they're asked to imagine their least anxiety arousing scene. And slowly they will move up the list until the client feels that they have a little anxiety about it. This will continually be a process. That's why it will take a little bit longer than most. Next, we have in vivo exposure and flooding. In vivo exposure and flooding are exposure therapies that are designed to treat fears and negative responses by introducing clients to the situation of causing problems. Exposure therapy, by either imagining it or experiencing it live, which is in vivo, is sometimes confrontational and not for everybody. So you have to make sure that your client is aware of what this process can honestly do to an individual. First, this process will start by talking about in vivo exposures by imagining situations that cause fears, which will also can sometimes be live. There are situations where if a person has a fear of flying because that it will crash, or they have a fear of driving because they were in a car accident, you can't recreate that situation because it is obviously harmful and that's not the correct way to do it. But the clients can be encouraged to go to live places that cause them fear, such as an elevator or an escalator or something simpler like that. Flooding is different than in vivo. So it's not just imagining it or completing it live. Flooding is a form of exposure therapy which can be live and or imaginal, but will happen over a long period of time. So it's not just a quick process. It's someone has to sit through this struggle of fear and anxiety, and they're exposed to this stimuli that has caused them fear. And after time, the client is attempted to not use anti-anxiety coping mechanisms. But at first, they want to know right whenever the anxiety begins, so they are able to understand the behavior of the client a little bit better. Both in vivo and flooding have been able to help social phobia, panic disorder, obsessive compulsive disorder, stresses, and many phobias of different kinds. Next, we have EDM, eye movement desensitization and reprocessing, which is another form of exposure therapy that involves assessment, preparation, imaginal flooding, and cognitive restructuring for treatment individuals with traumatic memories. In this treatment, there will be rapid eye movements and other stimulation that help to try to help clients with traumatic stress and dealing with traumatic stress disorder in general. Next, we have mindfulness and acceptance-based approaches. It's important to understand what mindfulness and acceptance truly means for these approaches to make a little bit more sense. So, acceptance, as the books say, is a process involving someone receiving one's present experience without judgment or preference, but with curiosity and kindness, and striving for full awareness of the present moment, excluding and taking away judgment, criticism, and avoidance, and replacing it with acceptance, is a wonderful thing that we can do for an individual. Mindfulness is the awareness that emerges through having attention on purpose in the present moment and non judgmentally to the unfolding of an experience. So, first, let's go over DBT, dialectical behavior therapy. DBT is a main way to help individuals with suicide or who have been diagnosed with borderline personality disorder. DBT is not a fast working approach. It's not going to happen in 6 weeks. It's not going to happen in 8 weeks. It's going to take a while for treating individuals that are suicidal. You don't just want to leave them on the curb and just stop this treatment. That's why it's longer and it has more of a process to it.